Hello and welcome back to Lecture 2 for Week 5, Module 3, Introduction to Community Health. In the last lecture, where we left off was Managed Care Organization Assessments, the NCQA, which is the National Committee on Quality Assurance, and HEDIS measures, the Health Plan, Employer Data, and Information Set. So I wanted to just cruise through the HEDIS website. And I thought it would be interesting to just show you some of the measures that they're using to track the effectiveness of care of these managed care organizations. So healthcare effectiveness data and information set is one of the most popular ways to measure and improve healthcare. It tracks the quality of care that 184 million people, or 57% of the US population, receive. It's a huge data set. The excerpt below includes measures from 5 domains of care: prevention, respiratory, cardiovascular, diabetes, musculoskeletal, behavioral health, medication management, overuse, measures collected through Medicare health outcomes, measure collected through CAHPS health plan survey, access, availability of care, experience of care, utilization and risk-adjusted utilization, measures collected using electronic clinical data systems. And just looking through these, we can go through a couple examples here. Weight assessment and counseling for nutrition, physical activity for adolescent and children. I like that they have this section about why it matters, and talks about the burden of disease or the prevalence of this condition in our larger population. I appreciate that this section is in here because sometimes for someone just, checking out this website who isn't conversant in why it matters, that's really important. So other than that, we have some of the results. BMI percentile, which was captured by some of these organizations, not by Medicare, because youth aren't generally covered in Medicare, so it's not applicable. But Medicaid, and by doing this, we can almost infer the income level of, so youth that are on Medicaid, you can imagine that they're coming from a lower income bracket family. Youth that are on PPO, their parents probably have a job with benefits. And so from a commercial, and same with HMO, their parents probably have a job with benefits or they're buying in. So you can kind of infer some things and use it as a proxy variable for income, if that's relevant to what you're measuring. So you have these measures, HEDIS measures, why it matters, the results, and sort of a general overview here. You have their data submission, if you want to know where the data comes from, measurement, certification programs. So these are interesting, and I've been to CMAR. They actually use HEDIS measures in the clinic itself for diabetes care, and these are up on the wall. So these are all the clinical measures of that are used for diabetes. HbA1c, hemoglobin A1c, refers to, it's a blood sugar measurement, and eye exams, nephropathy, blood pressure, why it matters, and they have the explanation here. And they also talk about the complications, which I find really helpful, and sort of a incentive to prevent the condition because complications come later down the line. So again, all the measures that they have here, they include here, results. And so that was just a quick look into HEDIS measures. So MCO issues. Physicians who contract with several MCOs are concerned with providing quality care to their patients because the MCO's focus is on cost. So that is an issue. As a result of their focus on cost, the physician's ability to practice without close monitoring of their choices can be limited. I think maybe in terms of referrals, it might be discouraged for ordering a lot of testing and things like that, but I also think it could be a good check and balance to not overuse certain services. So I think, it's a catch-22 sometimes, or not in a bad way, but it's a good check and balance for providers to have to think about the cost of what they're doing, both fiscally with the money, but also putting their patient through extra testing and extra procedures and extra time at the healthcare facility when hopefully it's necessary rather than avoidable and just being done. So surveys indicate that the more managed care networks the physician contracts, the less satisfied they are with managed care. So other issues with MCOs, physicians are also concerned with physician network rentals or silent PPOs, which are unauthorized third parties outside the contract between the MCO and the physician that gain access to the MCO discount rates. Examples of these network rentals are automobile insurers or workmen's compensation insurers. They obtain the physician's rates from a database. Other issues with MCOs, the main insurer who has the contract with the physician does not provide the information to the physician, and the third parties continue to benefit from the discounted rates. There are several states that prohibit these silent PPOs. So in summary, the managed care model for healthcare delivery was developed for the primary purpose of containing healthcare costs, and probably has to do with how a gatekeeper works in coordinating a patient's care, their referrals, their other conditions, and I think ideally focusing on preventive care and having a primary care physician that encourages them to take part in primary prevention, which we've talked about in this class, which is at the level of sort of personal behaviors, but also secondary, which is at the level of the clinic for screenings and for immunizations and things like that. And I think part of cost containment is maybe reducing referrals and testing through working with the primary care physician, but part of it is encouraging preventive services so that patients don't show up in the emergency room or with more severe health conditions later down the line. And also managed care model for health focus on cost containment by administering both the healthcare services and the reimbursement of these services, and therefore eliminating a third-party health insurer The industry felt that this model would be very cost effective. Both the consumer or patient and the physician's concerns were the same: worry about providing quality care while focusing predominantly on cost. The consumer was also worried about loss of freedom of choice of their primary care provider. The physician was worried about loss of income. So these are all things that are part of negotiating a managed care organization, is the quality of care, the pay of the physicians, all the juggling of running an organization like this. So in conclusion, see your chapter 9 of your book if you haven't read it yet. It'll solidify some of these concepts and go more into detail than I have done on many of these slides. And if you have any questions, let me know. Next week's assignment, which is the group presentation, you'll get more details about that soon, later this week. So just focus on your readings for now for week 5, and make sure you make an appointment for your midterm meeting with me, and looking forward to filling you in further on the week 6 discussion later in the week. So enjoy your day and have a great week 5.